بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we are going now to discuss one of the most important issues in the pediatric imaging concerning the diagnosis of hydrocephalus. And we will deal in this issue in two separate lectures. The first one will be about the hydrocephalus in general, and the second part of this talk will deal with the special types of hydrocephalus, including the posterior fossa malformations, Dandy Walker, and the Chiari malformations, as well as the holoprosencephaly and the hydranencephaly. Then first, you should know that hydrocephalus means that there is ventricular dilatation or enlargement of the cerebral ventricles, and it is referred to as water on the brain, CSF in dilated ventricles, or sometimes they call it increased intraventricular pressure. And in the CT scan or MRI, you will see dilated ventricles, whether they are only the lateral ventricles or the lateral and third or the lateral and third as well as the fourth ventricle. We will explain in details these issues. Then in the era before CT and MRI, we used to perform skull X-rays whenever we feel that the skull is enlarged or the craniofacial diameter is, the craniofacial ratio is disturbed, and we think that there is some sort of hydrocephalus. And here are the manifestations we were looking for. Number one is in the pediatric age group, widening of the skull sutures, increase in the craniofacial ratio. The skull is much more enlarged compared to the face, bulging of the fontanelles, and in adults we used to see erosion of the dorsum celli, and sometimes there is what is known as the silver bitten appearance in long-standing cases, which means that there is some indentations on the calvarial bones exerted by the convolutional markings of the brain. Then what is the difference between hydrocephalus and atrophy? And actually, you know that by definition, hydrocephalus means dilated ventricles, but in atrophy also the ventricles are dilated and the cortical sulci are dilated. Then we used to look for specific areas of enlargement and dilatation, particularly the recesses of the third ventricle and also the temporal horns, which are particularly dilated in hydrocephalus and not usually dilated in atrophic cases. And this is the third ventricle, and there are two recesses. The first one is related to the pituitary stalk and is known as the infundibular recess, and the second one is a little bit anterior, related to the optic tract, and this is known as the optic recess. Whenever the pressure increases in the third ventricle, there is marked dilatation of the recesses of the third ventricle. There are some angles, but they are no more used after the market development in the CT and MRI. Whenever you draw two lines parallel to the frontal horn of the lateral ventricles, you got an angle between the frontal horns, and this angle is usually obtuse. But in cases of atrophy, where you got the dilatation of the ventricles, the angle is usually not changed. But in cases of hydrocephalus, the angle is very narrow. Then dilatation of the ventricles and dilatation of the cortical sulci and the fissures means that you are most likely dealing with the case of atrophy. But dilated ventricles with loss of the cortical sulci, loss of the fissures. That's to say the brain is swollen, the brain is expanded, then this is the hydrocephalus. And there is also one of the signs. Let us see this example first, which is a case of brain atrophy, where you can see that the cerebral ventricles are dilated, the lateral ventricles are dilated, the third ventricle is dilated, but also you can see that the sylvian fissures and the cortical sulci are markedly dilated. Then dilatation of the ventricles and cortical sulci usually means that you are dealing with a case of brain atrophy. But if the cortical sulci are dilated, if the ventricles are dilated, but the cortical sulci are not dilated, as you can see in this case, the ventricles are dilated and the cortical sulci are effaced or lost. And this means that you are dealing with hydrocephalus. And what we call periventricular edema means that the CSF accumulated in the ventricles, which fails to go through the normal pathways, has no alternative to go retrograde through the ventricular wall, forming what is known as periventricular edema, which is batches of hypodensities around the ventricles due to what's known as retrograde transependymal CSF permeation. And this indicates that you are dealing with a case of obstructive hydrocephalus. Then we came to the normal flow of the CSF and its production. You know that the choroid plexus, which is located in all the ventricles, in the lateral ventricles, in the third and in the fourth ventricle as well. This choroid plexus is the main producer of CSF, and those who are mainly concerned are located in the lateral ventricles. The normal rate of production of the CSF per day is about half a liter, and this CSF is mainly produced inside the lateral ventricles. Then it flows into the third ventricle through the foramina of Monroe, and through the aqueduct of Sylvius, the CSF flows from the third to the fourth ventricle. Then through the outlet foramina of the fourth ventricle, the CSF, most of the CSF passes in the subarachnoid space around the brain, around the cerebral hemispheres as well as the cerebellum. Then some of the CSF will go inside the spinal canal. Then the CSF in the subarachnoid space will be absorbed by the arachnoid villi and directed to the superior sagittal sinus as a final stage. And production of the CSF occurs in the lateral ventricles, then to the third, then to the fourth, then to the subarachnoid space along the surface of the brain. Then it is absorbed by the arachnoid villi and directed to the sagittal sinuses, especially the superior sagittal sinus. Then obstructive hydrocephalus means that there is some way of or some cause of obstruction to the CSF flow in the ventricular circle or outside the ventricular circle. And the obstruction may occur at the level of the foramina of Monroe, or at the level of the aqueduct of Sylvius, or at the level of the outlet foramina of the fourth ventricle. And these levels, if there is obstruction at any of these levels, you call this obstructive non-communicating hydrocephalus. But the CSF can be also, the flow of the CSF can be also obstructed if there is damage of the arachnoid villi or occlusion of the superior sagittal sinus. Then at these two levels, the obstruction is known as communicating, obstructive communicating hydrocephalus, when it affects the arachnoid villi or the superior sagittal sinus. But the obstruction within the circuit of the ventricles is known as obstructive non-communicating hydrocephalus. And we start first by obstruction of the foramina of Monro, which may be unilateral or may be bilateral. And if you look for this example, this is the MRI axial and the coronal T1 weighted image because the CSF is black. Then the left lateral ventricle is of normal size and shape, but the right lateral ventricle is markedly dilated. And if you see a cause for obstruction and like a colloid cyst or a tumor of tuberous sclerosis, then the cause is evident. But if you don't see any cause for obstruction, and this is stenosis or marked narrowing, congenital narrowing of the foramen of Monro. And this is an example. You see the left lateral ventricle is good, the right lateral ventricle is markedly dilated, and you don't see a cause for obstruction at the level of the foramen of Monro. And sometimes in the brain tumors, you got a tumor like this with edema and marked mass effect on the right lateral ventricle. But if you look to the left lateral ventricle and you see that the ventricle is dilated, and this dilatation is because of the midline shift that will lead to kink of the foramen of Monro of the opposite ventricle and hinders the flow of the CSF in the ventricle or outside the ventricle, then the ventricle will be dilated. And these are two examples, glioblastoma multiforme in the right hemisphere and another one in the left frontal lobe. There is marked compression of the ventricle, shift of the midline structures, and the contralateral ventricle is dilated due to kink of its foramen of Monro. And if there is a lesion that can obstruct both foramina of Monro, like this typical lesion, which is known as colloid cyst, and the colloid cyst is usually located at the anterior part of the third ventricle, centered to the region of the foramina of Monro. This cyst is hyperdense in the CT images and may be also of bright signal in all MR images. Then the lesion in a strategic location will compromise the foramen of Monro on the left as well as that on the right, resulting in dilatation of both lateral ventricles. And in cases of tuberous sclerosis, you see periventricular subependymal calcifications, and these are one of the stigmata of tuberous sclerosis. And in some cases of tuberous sclerosis, the patient may got a tumor in the frontal horn of the ventricle, and this tumor is known as subependymal giant cell astrocytoma. The tumor is particularly located in the frontal horn of the ventricle, and it shows homogeneous enhancement if you inject contrast material. And being intimately related to the foramen of Monro of the same ventricle as well as that of the opposite ventricle, it may cause obstruction of both foramina of Monro. This tumor is known as subependymal giant cell astrocytoma, and this is a CT scan of a case of tuberous sclerosis diagnosed by the presence of subependymal foci of calcification in the wall of the ventricle. And in the frontal horn, you can see a tumor which is enhancing diagnostic of subependymal giant cell astrocytoma. Then we came to the next station, which is the aqueduct. And the aqueduct connects the third to the fourth ventricle, and there are many causes for its occlusion. Number one, the congenital, which is a congenital aqueductal stenosis. Number two, inflammatory lesions like encephalitis, multiple sclerosis, cysticercosis, and neoplasms like brainstem glioma, or particularly pineal body tumors, which are located exactly near the site of the aqueduct of Sylvius. Aqueductal stenosis is responsible for about 20% of the causes of hydrocephalus in the pediatric age group. Then how can you diagnose aqueductal stenosis? There should be dilatation of the third ventricle and the lateral ventricles, but the fourth ventricle is good. And here you can see a normal sized fourth ventricle, but the third is dilated and the lateral ventricles are dilated. Then you know that the obstruction should be between the third and the fourth in the region of the aqueduct. And you may use the sagittal MRI images, and also you can use the recent technique of CSF flowmetry by MRI to judge the flow within the aqueduct. And this is the region of the aqueduct. This is the fourth ventricle and this is the third ventricle, and the aqueduct should be here. But actually you cannot see the aqueduct, it is stenotic, and you cannot rely upon this image as for diagnosis, because if the section is not well oriented to the anatomic course of the aqueduct, you cannot see it. But you see that the fourth ventricle is of normal size, but the third ventricle is dilated and the recesses are distended. Also, the lateral ventricles are dilated. Then this is an example of aqueductal stenosis where you can see that the fourth ventricle is of normal size, the third ventricle is ballooned, and both lateral ventricles are dilated. And this is an MRI case of aqueductal stenosis in a male 17 months old. You see that the third ventricle is ballooned and the lateral ventricles are dilated. In the sagittal image, you can see that the fourth ventricle is more or less good, and the third is hugely dilated as well as the lateral ventricles. Then neoplastic causes of aqueductal stenosis include one of the well-known pediatric tumors, which is the brainstem glioma. And here they see that the bones is infiltrated by a big hypodense mass with some areas of enhancement. I will discuss in full details imaging of the pediatric brain tumors in 2 separate lectures, inshallah. Then you see there is marked compression of the fourth ventricle. There is marked encroachment on the distal part of the third ventricle as well as the region of the aqueduct. And you can see that the third ventricle is ballooned. The lateral ventricles, including the temporal horns, are dilated. And you see some periventricular edema, which indicates retrograde transependymal CSF permeation. And one of the important notes is if you see the manifestations of aqueductal stenosis in an adult, then be careful. You see here in this particular example that the lateral ventricles are dilated and the fourth ventricle is not. And in this MRI, you see the lateral ventricles are dilated, the third is dilated, but the fourth is good. Then this is known as late onset aqueductal stenosis. And if this diagnosed by CT, you should have MRI looking for an important lesion in the tectal plate of the midbrain. And look here and you see this is the fourth ventricle, which is of normal size, but the third is dilated and the fourth and the lateral ventricles are also dilated. And this is the lesion I'm talking about. In this particular case, you see that there are dilatation of the lateral ventricles and the third ventricle is ballooned. Then by CT, you cannot see this particular lesion. In the anatomy, you know that this is the quadrigeminal cistern. And the quadrigeminal cistern borders the tectum of the midbrain posteriorly. Then you see this area of abnormal signal, which is of a little low signal in the T1 and the high signal in the FLAIR image, as well as in the T2 weighted image. And this is tectal plate glioma. Then this glioma is difficult to be diagnosed by CT. Then if you are confronted by a case of late onset hydrocephalus stenosis, you should have MRI looking for this particular lesion. Of course, you may see it, or the patient may not have a tectal plate glioma and they have other causes for aqueductal stenosis. Then we came to the fourth ventricle, and the fourth ventricle is obstructed through its outlet foramina. We may get atresia of the outlet foramina of the fourth ventricle, inflammatory changes around and in the fourth ventricle, and neoplasms in the posterior fossa like medulloblastoma, astrocytoma, brainstem glioma, ependymoma, and metastasis, hemangioblastoma. There are a lot of tumors that occur in the posterior fossa. Then, if you look for this example and you see that the fourth ventricle is markedly dilated, the third is also markedly dilated, the lateral ventricles are markedly dilated, and this means that you are dealing with the case of atresia of the outlet foramina of the fourth ventricle. This is the difference between aqueductal stenosis and atresia of the outlet foramina. In the aqueductal stenosis, the fourth ventricle is of normal size, but in atresia of the outlet foramina, the fourth ventricle is ballooned, the third is ballooned, and the lateral ventricles are markedly dilated. And this is an example of atresia of the outlet foramina of the fourth ventricle. You see the fourth ventricle is hugely dilated, the third is also, and the lateral ventricles are also dilated. Then look here for another case in male infant, 3 months old, and you see the fourth ventricle is dilated and the third ventricle is dilated. The lateral ventricles are markedly dilated. This is a case of atresia of the outlet foramina of the fourth ventricle. And this is another case, dilated fourth ventricle, dilated third, and dilated lateral ventricles. Then these are some of the examples that can of brain tumors occurring in the posterior fossa. This is the case of ependymoma centered to the region of the fourth ventricle, showing matrix calcification with dilated supratentorial ventricles. And this is the case of medulloblastoma. I will mention in details how can you discriminate between these tumors. And this is the third, and these are the lateral ventricles which are dilated. And this is typical example of pilocytic astrocytoma, the cystic lesion with an enhancing mural nodule with supratentorial hydrocephalus due to compression of the fourth ventricle. Then we came to the stage of obstruction outside the circle, the ventricular circuit. Then here the obstruction is in the arachnoid villi. Any pathology that can cause damage to the arachnoid villi will hinder the absorption of the CSF, leading to accumulation of the CSF in the ventricular system and the development of hydrocephalus. The main causes of damage of the arachnoid villi are basal meningitis, subarachnoid hemorrhage, and meningeal carcinomatosis. Then assume that the arachnoid villi are good and the sinus is thrombosed. Then the arachnoid villi will absorb the CSF, and there is no way to drain the CSF into the venous side because the dural sinuses are thrombosed. And this is an example of subarachnoid hemorrhage, and you see the hyperdense blood in the suprasellar cistern, in the sylvian fissures, and you can appreciate the degree of dilatation of all ventricles, the fourth, the third, and the lateral ventricles. And there is a big difference between obstructive communicating hydrocephalus and atresia of the outlet foramina of the fourth ventricle. In cases of atresia, the fourth ventricle is ballooned, but in cases of obstructive communicating hydrocephalus due to arachnoid villi abnormality, the fourth ventricle is dilated but maintaining its normal shape, and this is very important. This is also a case of subarachnoid hemorrhage, and you see hemorrhage in the interhemispheric fissure, hemorrhage in the sylvian fissure, and hemorrhage inside the ventricles as well. And this section shows the most upper part of the fourth ventricle. It's not showing the fourth ventricle in the posterior fossa. Then obstructive communicating hydrocephalus means that there is a problem in CSF absorption and the drainage via the arachnoid villi or within the venous side. And this is an example of basal meningitis. This patient is injected with contrast, and you see enhancement in the basal cisterns, enhancement in the quadrigeminal cistern, enhancement in the superior cerebellar cistern, and enhancement of the meninges also. Then this will be meningitis. And this is also another example. There is a lecture which will deal uh, with the imaging of intracranial infections in the pediatric age group, and I will discuss also in details, inshallah, the different types of meningitis, encephalitis, and cerebritis in the pediatric patients. This is a T2 weighted image, and this is flare, and this is T1 post contrast. And here you can see that there is some enhancement in the basal cistern and in the basal ganglia, as well as in the sylvian fissures with dilated ventricles due to communicating obstructive hydrocephalus. And this is a case of meningoencephalitis, where you can see thickened enhancing meninges as well as changes in the brain parenchyma with heterogeneous enhancement diagnostic of meningoencephalitis. Then sometimes you are confronted by a case like this, and you see that the fourth ventricle is dilated, maintaining its normal shape. The third is dilated, and the lateral ventricles are dilated. You know that this is communicating obstructive hydrocephalus, but you cannot see the cause. And the cause is usually known from the history. Either this patient had a previous attack of meningitis or a previous attack of subarachnoid hemorrhage, for example, and the attack was medically controlled, and the remaining complication in the form of communicating hydrocephalus is still there. And this is an important issue I would like to talk about, which is known as trapped fourth ventricle. And this trapped fourth ventricle means that the fourth ventricle is hugely dilated because it cannot drain its CSF through the outlet foramen. What happens is the patient starts by the diagnosis of aqueductal stenosis. The aqueduct is stenotic and the supratentorial ventricles are shunted. Then later on, the outlet foramina of the fourth ventricle are occluded. Then there is choroid plexus inside the fourth ventricle producing CSF. And this CSF cannot go upward through the aqueduct because it is stenotic or congenitally stenosed. And it cannot go outside the fourth ventricle through the outlet foramina because they are occluded. Then this condition is known as trapped fourth ventricle. The fourth ventricle is markedly dilated. The patient is known to have aqueductal stenosis that was shunted, and the symptoms will include will be similar to a posterior fossa tumor or a specific lesion like ataxia, diplopia, and so on. Then look at this case. There is aqueductal stenosis which has been shunted by this shunt tube. The patient developed subdural hematoma, and this was one of the known complications in the era of old shunt tubes. But look at the posterior fossa sections, and you see that the fourth ventricle is dilated, and there is periventricular hypodensity due to retrograde transependymal CSF permeation, and this is known as trapped fourth ventricle. Trapping of the fourth ventricle occurs in patients who had previously aqueductal stenosis that was shunted. Then, for some reason or the other, the patient developed occlusion of the outlet foramina of the fourth ventricle. Then you see that the fourth ventricle is ballooned because the CSF inside the ventricle is trapped. Then we came to another issue, which is the normal pressure hydrocephalus. And by this, we mean that there is some ventricular dilatation, but we do not have a an evidence of increased pressure inside the ventricles. And the most likely imaging finding to support it that there is some increase in the ventricular pressure is the detection of periventricular edema due to retrograde transependymal CSF permeation. And you remember that I have said if the ventricles are dilated and the cortical sulci are dilated, and this is atrophy. If the ventricles are dilated and the cortical sulci are not seen, and this is hydrocephalus. But if the ventricles are dilated and the cortical sulci are normal, then consider the possibility of normal pressure hydrocephalus. And there are some imaging findings to help you for the diagnosis. Number one is enlarged ventricle with normal cortical sulci, like in this example. And periventricular edema may not be seen. If it is seen, this means that there is some increase in the intraventricular pressure, and this may guide the surgeon to put a shunt tube where the patient will make benefit of this shunt tube. Then increase flow within the aqueduct, and this can be easily appreciated in MR images where you see the region of the aqueduct, and this T2 weighted image the aqueduct should show high signal because of its CSF content. But if the flow of the CSF is high, then you got what's known as signal void, and the aqueduct will appear black, as you can see here, due to the flow void CSF. And one of the findings is upward bowing of the corpus callosum. And you see this stretching and upward bowing of the corpus callosum. And this is an example, and you see the ventricles are dilated and the cortical sulci are normal, and the corpus callosum is stretched and bowed upward. Also, sometimes they call this central brain atrophy, meaning that the central part of the brain is atrophic, so the ventricles are dilated to compensate loss of volume. While if the cortical tissue of the brain is atrophic, the cortical sulci will be dilated. Then there are some criteria to guide the surgeon if this patient will benefit from the shunt tube or not. And these criteria include abnormal gait, upward bowing of the corpus callosum, ballooning of the third ventricle, known history of subarachnoid hemorrhage or meningitis previously, and you should not see in the scans evidence of cerebral atrophy or infarctions. Then this is a normal pressure hydrocephalus. The ventricles are dilated, but the cortical sulci are normal. Then this type of hydrocephalus is the what is known as non-obstructive. The previous two types are the obstructive hydrocephalus, either within the circuit of the ventricles or outside the ventricles in the arachnoid villi or in the dural sinuses. But this hydrocephalus is due to CSF overproduction, and this occurs when the patient had a choroid plexus papilloma. The choroid plexus papilloma is a tumor affecting the choroid plexus, which produces CSF. And you know that the normal rate of CSF production is about half a liter per day. In some cases of choroid plexus papilloma, the rate of CSF production is about 2.5 liters per day. Then there is an overflooding of the ventricular system by CSF, where the arachnoid villi cannot cope with this marked amount of CSF production. Then you see the tumor within the ventricle corresponding to the site of the choroid plexus, and you see dilated ventricles. And in this example, you see a shunt tube, and this air is due to the shunt, and you see the tumor in the occipital horn of the left lateral ventricle. Finally, we would say something about the shunt tube complication. And in sometimes you may put in the shunt in a wrong place, or the shunt may be occluded and is not working good, or the shunt may be infected, or and sometimes in the old types of the shunt tubes, the patient may develop subdural hematoma. And finally, we will talk about the slit ventricle syndrome. And in order to know that the shunt tube is functioning good, you should have the pre-shunt and the post-shunt exams. And this is the pre-shunt CT, and after shunting, you see that the ventricles are maintaining or regained to the normal size and configuration. And you know that the ventriculoperitoneal shunt is the distal part of the shunt tube is in the abdomen. Then, in cases of infection in the abdomen, like peritonitis or trauma or so, the this infection may go to inside the ventricles via the shunt tube. Then, if the ventricles are inflamed, then you know that this is known as ventriculitis or ependymitis. The ventricles are dilated and the wall of the ventricle is enhancing, taking contrast media, exactly similar to an abscess. And the ventricle is transformed into an abscess at that time. And this ventricle is also showing enhancing of the ventricular wall. Then if you see enhancement of the wall of the ventricle, whether the ventricles are dilated or not, then you know that you are dealing with a case of ventriculitis or ependymitis. And at that time, the ventricles will be transformed into abscesses. And in the previous days, with the use of the some of the old shunt tubes, if you put the shunt tube, it will lead to sudden decompression of the ventricle with the development of variable-sized subdural hemorrhage. And this is a shunt tube with bilateral chronic subdural hematomas. And this is also a shunt tube with marked ventricular decompression, and you see bilateral subdural chronic subdural hematomas. Then what do we mean by the slit ventricle syndrome? If you put the shunt tube and the shunt is working, then the ventricle will be decompressed. And after that time, with regular follow-up, you see, in particular in this example, you see that the ventricles are attenuated and the shunt tube is present. There is some subdural hemorrhage, chronic subdural hemorrhage as a complication of this shunt tube. And if the patient is not complaining, and it comes only for follow-up of the shunt, whether it works or not. Then you see the ventricles are collapsed, and this is not considered as a slit ventricle syndrome. So when you consider that this appearance is slit ventricle syndrome, you know, chronic overshunting will lead to decompression of the ventricles, and by time the ventricular wall will be fibrosed. Then, if the shunt tube is obstructed and the choroid plexus in the ventricle is producing CSF, and the shunt cannot drain this CSF, and the ventricle cannot expand because of its fibrotic wall, then the patient will complain of symptoms of hydrocephalus, where in the images you see that the ventricles are normal. And this condition, you call this slit ventricle syndrome. And chronic overshunting will lead to decompression of the ventricle. Over a long time, the ventricular wall will be fibrosed. If the shunt is obstructed, then the CSF will be accumulating in the ventricle, and the ventricle cannot expand, and also the shunt cannot drain the CSF, and this is known as slit ventricle syndrome. Alhamdulillah Rabbil Alameen. Thank you very much.